Okay, at this time, I'd like to introduce Dr. Tammy Singleton, who is going to be our speaker today. Dr. Singleton is the Chief of Pediatric Hematology and Director of the Hemophilia Treatment Center at the Mississippi Center for Advanced Medicine and the Louisiana Center for Advanced Medicine. Dr. Singleton has served as principal investigator for many clinical trials and has a special interest in gene therapy. Welcome, Dr. Singleton.
Hi, thank you so much. Thanks, Brendan. I really appreciate that. Hi to everybody out there. I bring you greetings this afternoon. It's a lovely, lovely sunny afternoon, actually, here in the South Louisiana / New Orleans area. It's still pretty hot here. I am so excited to be here with everybody. I was just saying to everyone, the only thing that would make this even remotely better is if we could be in person, but that is okay. We're going to have a great time and talk about gene therapy and some basic concepts so that we can start to answer this question, where do we go from here with gene therapy? So as we go along, please make sure you type your questions in the chat. I'm going to leave some time at the end so that we can have a really robust conversation, I hope. So let's go ahead and dive in. So here are my disclosures. Did you take a look? All right. So I always like to start our conversations with a reminder and a visual of what are we talking about? What happens with coagulation? Why do we even have questions about gene therapy in the first place? So I usually like to share the model of coagulation that I want everyone to forget, and that's those Roman numerals on a white piece of paper, right? But this is one of my favorite models of coagulation that I borrowed to show you that coagulation doesn't happen on a piece of paper. It actually happens on a cellular level, and it's a real entity. So I want you to focus. This is an example of an injury. And I want you to focus center stage at that activated platelet that you see there at the bottom. That activated platelet is the cell surface where all the action happens, is where the party happens. It's where we need factor 8 to complex with factor 9 to then activate factor 10, and you have thrombin formation. Now, are there other factors in the coagulation cascade? Absolutely. And one of my favorites there is represented by that yellow chain link fence looking thing, factor 13. But the main portions, the center stage of coagulation, is factor 8 complexing with factor 9 so that you can have factor 10 activation and thrombin formation. So when we're talking about hemophilia, we're talking about the absence of factor 8, the absence of factor 9, and then you don't have that factor 10 activation, right? So I bet you always want to know that. So just again, as a reminder, as we talk about gene therapy, we're talking about gene therapy in relation to hemophilia. So we are certainly familiar with these numbers. We know that we have patients here in the United States, roughly about 20 to 25,000 patients that have hemophilia in general. More patients are affected by factor 8 deficiency or hemophilia A than patients with factor 9 or hemophilia B. And so you can see there, it's in one in about every 5 to 7,000 births or boys for factor 8 deficiency or hemophilia A, whereas hemophilia B or factor 9 deficiency occurs in about 1 in every 25 to 30,000. Now, what you see to the right is what we already know as well, that normal factor levels are, and depending on the normogram, sometimes you'll see normal factor levels with an adjustment of 45%, sometimes 40%, but on an average, 50% is that lower end of the threshold, whereas 150% is that upper end of that threshold for both factor 8 and factor 9. Now, we have patients that have mild hemophilia, moderate hemophilia, and severe hemophilia. Mild hemophilia, those guys can be very interesting because the factor levels can exist with a very wide range, anywhere from 5 up to just below 50%. Moderate patients are incredibly interesting as well. That range from 1 to 5%. You can certainly have bleeding after surgical procedures, and bleeding can occur spontaneously. And depending on the baseline level of factor present and the injury that occurs, you can see some pretty significant bleeding, and many of those patients require prophylaxis. What we're going to focus on with this question with gene therapy, and where do we go from here? We're focusing on patients with severe hemophilia. So less than 1%, both hemophilia A and hemophilia B patients, where we see that frequent spontaneous bleeding, where we see patients diagnosed very early on in childhood. So focusing again on those severe hemophilia A patients. So to the left, you see those unmet needs, basically sort of in a time-wise fashion. To the right, you see the resulting innovation. So we have accomplished so much in the hemophilia community over the years. The development of plasma-derived factors so that we could prevent bleeding in the first place. When we faced the HIV and Hep C crisis, there was a demand for safe products. And so we had recombinant products that were developed. The concept of prophylaxis, focusing on bleeding, focusing on joint bleeding, fighting that concept has become a staple, right, in our community. Emicizumab, that was a game changer for a lot of patients, a subcutaneous option. It is also introducing a concept that is a non-factor replacement related therapy. We're going to talk a little bit more about that here in just a second. But these innovations sort of keep coming. What's also incredibly important is that in general, the average life expectancy of a patient with hemophilia is the same as any other American here in the United States. Joint disease is virtually non-existent in young patients without an inhibitor. And I'm going to emphasize virtually, because we absolutely still have patients with joint disease, and sometimes joint disease unbeknownst to the patient sometimes. But we certainly have remaining needs, right? Venous access, because therapies are typically infused. That can be a significant challenge. The whole burden of infusions, the annualized bleeding rate, still wanting to make sure that we keep that as low as possible. We still have patients on on-demand therapy. The concept of microbleeding, and how do we address that? So we know that bleeding rates are not zero. So future innovations are sort of what we're going to focus on as we talk about gene therapy and some of those novel or non-factor replacement therapies. And I'll talk a little bit more about that at the end. So again, focusing on those unmet needs, right? So we have certain barriers that we still need to overcome. Again, venous access is still a significant issue. We talk about it every day here in clinic. Significant cost is an issue. It's an issue especially to patients who are not insured or underinsured. And of course, unsatisfactory access to healthcare. I think in the past year, we've all learned so much about the definition of access to healthcare. I know that I have certainly changed significantly over the past several years in my understanding of access to healthcare. That's a really big topic, and maybe we can talk about that next year just as a topic all by itself. But our patients that have inhibitors, still the most significant challenge in hemophilia, and the success rates of immune tolerance, uncertainty in terms of emicizumab, how to use it with immune tolerance. So lots of questions, and I'll mention a little bit more about that at the end as well. And then, of course, we have current treatment limitations. I already mentioned that joint disease has decreased significantly, and we're all aware of that, but it still happens. It's still happening. So how do we change this? Well, we have a lot of questions in terms of the impacts of things and how can we move forward. So we're looking now at a shift in terms of the paradigm that we once had with hemophilia and how these innovative therapies are causing things to change. Now, what's so interesting about the concept is that with hemophilia, you have something that's missing, right? So factors missing, and there's that whole total imbalance in terms of having proteins that are available for clotting. On the other side of that scale with hemophilia, you could think of your thrombotic system, the whole balance. For many folks, that is still completely intact. However, we want to focus on where we are now and some of the alternative therapies, the newer therapies, again, some non-factor replacement therapies. But with factor replacement, you have restoration of the balance. And that has been and will always be the cornerstone of treatment and therapy in hemophilia. Replacing what's missing and understanding factor replacement restores the balance. So with that, we have standard half-life products. We have extended half-life products. We have bypassing agents for patients with inhibitors who don't respond to factor products. And we now have substitution like products of factor VIII. So those bispecific monoclonal antibodies like emicizumab, that binding of activated factor IX, binding to factor X, again, sort of mimicking the presence of factor VIII, providing some restoration and balance there. Gene therapy, what we're going to talk about here just shortly, is also a concept where we could replace what's missing, just in a different kind of way. Now, those other or alternative therapies that are non-factor replacement therapies, and technically emicizumab is one of those that are in the pipeline. They're still in clinical trials. I'm going to mention a little bit about that to you guys at the end as well. They also have different delivery systems. So many of them are not infused intravenously. So we have anti-TIFP inhibitors. So tissue factor pathway inhibitor, and an antibody to that. One of your body's natural anticoagulants. Antithrombin 3, again, one of your body's natural anticoagulants. Fitusiran has a little small interfering RNA that kind of keeps that antithrombin development at bay. And then, of course, we have protein C inhibitors and other agents. We'll talk a little bit more about that at the end as well. But again, restoring that balance is really what we're talking about when we talk about gene therapy. But first things first, I think it's super important that we try to make sure that we're all speaking the same language. So I know that we've all heard a lot about RNA, messenger RNA, DNA. So let's take a step back first and ask the question, what is DNA? Because we have to understand that concept and to make sure that we're all on the same page before we start talking about genes. So for each of us, we have DNA contained in our cells. It's contained in our cells with 23 pairs of chromosomes. So I, for example, have 23 chromosomes from my mom, 23 chromosomes from my dad, totaling 46, but I have 23 pairs of chromosomes which contain DNA. So in the cells in my bone marrow, in the cells in my eye, in the cells in my blood, those cells have an outside layer, right? The cellular layer. They also have the brain of the cell called the nucleus. Well, that is where DNA is housed, right? So DNA is made up of chromosomes. You find them inside the cell, inside that nucleus. Now, what does DNA do exactly? So DNA is like a set of instructions. The DNA all by itself doesn't produce proteins or makes my eyes brown or makes my skin an olive complexion or makes my hair super curly and dark. But DNA provides the instructions, the information, the building blocks, those chromosomes inherited from mama and daddy to determine our characteristics. Very interesting, isn't it? So you have DNA, which is made up of chromosomes included in the cell. So those genes, so chromosomes, are made, that we have genes, and genes are made up of components called nucleotide bases. So there you see represented that kind of universal symbol in terms of DNA, that double helix. Each of the little circles represents a gene, right? Or represents a gene. You have nucleotide base pairs, and those are the building blocks of a gene. So what happens with those nucleotide bases and they pair with each other? So just like letters in a word, nucleotide bases, they have to appear in a certain order. They can't be spaced too far apart. They can't reverse themselves. They can't have pieces missing. They can't lean to the left or lean to the right. So if you take a look at the example here, the nucleotide bases are organized in a way to spell green. So let's just pretend it's spelling green eye protein. So you come along and read messenger RNA is reading, so it develops then the protein, green eye protein. So it would read G-R-E-E-N, green eye protein, G-R-E-E-N. Just like letters in a word, it has to be read and read perfectly. If they are in the wrong order, the gene cannot provide the correct instructions and the protein can't be made. So we can't make green eye protein if we're reading N-E-E-R-G. It's flipped over or in the reverse order. So then the protein will not be made. When that happens, that is referred to as a mutation, a change in the gene. Here, it's inverted or flipped over. It's not in the correct order. So the little blue dot there represents a single mutated gene, very much like something that happens in hemophilia. A single mutated gene, and that mutation can take place in multiple ways. It can be like this, where it's inverted or flipped over. It can be where there's a piece missing, a slice missing, a large deletion, a small deletion, leaning too far to the left, leaning too far to the right, and it cannot be read in perfect order. So when we talk about genetic mutations causing a genetic condition, this is the level on which this happens, and this is an example of actually what's happening. So when we talk about gene therapy in hemophilia and the possibility of restoring normal factor production, even the possibility of that, what happens? Well, in the laboratory, you can see again that representation of the double helix. You have DNA that has been encoded or manufactured, changed in the laboratory to have a functional gene there to make factor 8 or provide the instructions to make factor 8 or make factor 9. That's an example of what happens. So a functional gene is created in the laboratory with the appropriate instructions to code for to make factor 8 or factor 9. Now, what happens with that functional DNA? When we're typically talking about gene therapy, we're talking about gene transfer. So that involves a vector, a vehicle. A vector is the empty shell of a virus that will then contain the functional or working DNA. Now, what happens with gene therapy in gene therapy clinical trials is that that gene or the vector with the gene in it, right? So that therapeutic vector is then infused. You see my little IV there representing the infusion. When the vector enters the body, that certain type of vector knows how to find a liver cell. The vector enters the human cell, and I want to draw your attention to the fact that you see the double helix still represented there as the DNA, as the chromosomes, as the genes in that liver cell. And that functional copy of the DNA will separately exist within inside the cell. What you can see represented there, we refer to that many times as like an episome, right? A circular portion of DNA. Well, now that that new DNA is inside the cell, the expectation, the thought, the investigations in gene therapy clinical trials are to determine if that new or functional gene will now make new clotting factor proteins that are in the bloodstream. Now, we refer to this as gene transfer because it is a vector-based delivery system. The functional gene that was created in the laboratory is delivered into the body, into a liver cell, by that empty viral shell. We refer to that as a viral vector. So gene therapy has the potential to lessen disease severity. The questions that are being asked in gene therapy clinical trials, does that actually happen? Is the protein being produced in a sufficient amount, concentration, or quantity, as it has been delivered using this vector-based delivery system? The questions are, will it remove or alleviate the need for repeated doses of factor replacement or prophylaxis or factor delivery, right? Or factor infusions. A number of trials have now been initiated. If you have questions about what clinical trials are open, what clinical trials are enrolling, if clinical trials regarding gene therapy, if it's even right for you, the first place to start is to have a conversation with your hemophilia provider, with your HTC. The other place that you can investigate the status of clinical trials with gene therapy is to take a look at clinicaltrials.gov. Now, one of the questions that is always asked when I present this information or we talk about what happens with gene therapy is, well, what happens with my genes? What happens with my mutation? Well, what happens is the original genetic material is unchanged, which means that the mutated gene is still there and could be passed on to a person's children. So your genes are still intact. The functional copy of the gene or the DNA has been infused and is separate, does not integrate into your genes. Your chromosomes remain untouched. Does that make sense? So that functional copy of the DNA is there, and the question is being asked, when that functional copy is in the cell, will it produce clotting protein, factor 8 or factor 9, in a sufficient quantity? Now, how are new treatments studied and what happens before they are approved? Now, we've heard a lot about that recently, right? FDA approval, especially this week. So let's take a look at what happens with that with the FDA. Really interesting information, and this model absolutely applies to any gene therapy clinical trials. So you first start with laboratory research. We refer to this as preclinical studies. This can be on an average several years, could be a year depending on the investigation, but typically a therapeutic question is tested in animals in the laboratory. Basic questions are asked regarding safety, sometimes mechanism of action, but typically it starts with those preclinical trials. Now, before we move to humans, where you see clinical trials here, that is what occurs. In humans, we have 4 different phases of a clinical trial, the first 3 of which will occur before FDA approval. So typically what happens is you have phase 1, where you have studies that are asking questions specifically about safety. Pharmacokinetics may be studied, what dose of this do we need to achieve this level? So you guys are familiar with that concept too, kind of pharmacokinetics. So pharmacokinetics and safety. Small group of patients, typically it can be healthy volunteers. It can also be people with certain conditions. But the question on a phase 1 trial is not really how efficacious it is or how well will it work in a condition. The big focus in a phase 1 trial is safety. In a phase 1 trial, you can then take that information and then move to a phase 2 trial. Now, sometimes these phases can be combined. It can be a phase 1 trial asking safety questions, and then you start to add more people to the trial and you can gather additional safety information while providing the therapeutic treatment option or the therapeutics product to patients that have specific conditions. You have now more people participating. This can happen over months to years, depending on the question that's being asked. Now, phase 3, you have even more people. Now you have more intense data, very specific questions that are asked regarding efficacy, how well does it work in certain conditions, but still a huge focus on safety, continued safety, what is happening now that we're having even more people participate in phase 3. In addition to that, in phase 3, there's a huge concentration on making sure that all of the checklists, all of the questions that the FDA would ask regarding this possible therapeutic option would be answered in phase 3, because after phase 3 is when a product can be submitted to the FDA for final approval. Once that final approval happens, it doesn't end. It meaning the studies and the investigations. Even after the FDA approves a product, even after the FDA approves a therapeutic option, you still go on to phase 4, which would be post-approval monitoring. So even unbeknownst to you, when you're taking a product or you're utilizing a therapeutic option, the FDA is still watching. So that is why we continue to have reporting requirements because that is still ongoing and happening. Now, it's important that we know, since we're talking about gene therapy, that with all of this information, looking at the preclinical information in terms of how studies start, understanding clinical trials, phase 1, phase 2, phase 3, no therapies, and there are multiple clinical trials in gene therapy, but no therapeutic option in terms of gene therapy has been approved by the FDA. So we have clinical trials that are out there. Remember, you can talk to your provider about the availability of clinical trials with gene therapy. You can research on your own, clinicaltrials.gov, and then have a conversation with your hemophilia doctor, with your hemophilia provider, with your HTC, to have an understanding of what this all means, which studies are open, which studies are using vector, AAV5 or AAV6. So you may have a lot of different questions, but nothing has been finally approved by the FDA. So in terms of where are we going from here, if you have questions or an interest in gene therapy, it has to still be done within the clinical trial setting. So one of these phase 1, phase 2, phase 3 like studies. So I hope that that makes sense as well. I want to just go ahead and address one quick thing. And I'm going to mention it a little bit here in just a second. But as we talk about with gene therapy, and when we're talking about hemophilia, we're referring to a vector-based delivery system, right? It has to have a vehicle to deliver the functional DNA that has been created. Well, typically that is a shell of a virus. It does not contain the DNA of a virus, so it can't make you sick like a virus. It's just used as a vehicle. The DNA of the virus is not there. It's an empty shell in theory. And then you have the functional DNA that is inserted, right? So it is not a virus that will make you sick, but because the shell is still there, it's possible that it may have been a virus that you've been exposed to in the past. And if you have antibodies to that viral shell, many clinical trials have built into the eligibility criteria that you will then be excluded from participation. So typically, a blood draw will determine if you're eligible to participate in a gene therapy clinical trial for hemophilia in any of these phases that you see here, represented here, phase 1, phase 2, phase 3, in terms of clinical trials. And I say typically because things may differ from study to study. All right, I'll have questions. Now, what are gene transfer clinical trials evaluate? Now that we understand that process. So again, the question is, can we introduce a functional gene, a gene that has been created in the laboratory, a functional gene that is programmed or has the information to then make or create in the bloodstream factor 8 or factor 9? Can it be introduced? We're also asking questions, can we produce an appropriate amount of factor 8 or factor 9 as a protein after we introduce this functional gene? So those are questions related to efficacy. How well does it work from a gene therapy standpoint? Can the symptoms of hemophilia or the need for treatment be reduced if we introduce the functional gene appropriately and we're producing an appropriate amount of protein? So does that change the treatment needs? Again, looking at the efficacy, like how well is it working? And in accordance with what we typically need to see with clinical trials, what are the short and long-term safety effects? Again, always asking questions about safety. So you see here these very specific goals related to gene transfer and clinical trials. Now, I have not mentioned any specific clinical trial for gene therapy in hemophilia today, but I do want you to know and to remember, if you have questions, additional questions that are specific to you regarding gene therapy, the best place is to always talk to your hematologist, talk to your HTC, but certainly you can get some additional information so that you can have questions prepared by going to clinicaltrials.gov. You can find some details there and then sort of sort it out with your treatment center if you have any questions about gene therapy and if it would apply to you. Now, in terms of additional considerations, so remember we talked about those unmet needs in terms of gene therapy at the outset? Well, we want to reduce or eliminate those spontaneous bleeding episodes. That is an unmet need. We still have those. Reduction or elimination on the dependence in terms of factor infusions, those frequent infusions. Can that unmet need be addressed? Steady ongoing concentrations of factor. Now we have current therapies, short half-life products, long half-life products, bispecific antibodies, but is it possible with gene therapy that we could address this unmet need of steady ongoing concentrations of factor? Again, all questions are being asked in terms of gene therapy. Now, what are some of the limitations that could be in place in general with gene therapy? I'm sure that you could come up with some more as well, but not all patients with hemophilia will be a candidate for gene therapy, either in the clinical trial setting or in general, even after something is FDA approved, because there will be various determinants. So you would need to be otherwise healthy, for example, but the really big one may involve, remember that question, that blood test in terms of antibody production. Do you have an existing sensitivity because you have antibodies that are present to the shell, that viral vector, because you've been exposed to that particular virus at some point in the past? Now, some people may not want to receive gene therapy. And in addition to that, for other reasons, it may not be an optimal course of therapy for everyone. I also have to add that currently gene therapy clinical trials have only been to date approved for adult patients who are 18 years of age and older. So that's yet again another issue. So there are viable options now. We have short-acting factor replacement therapies that work well for people. We have extended half-life factor replacement therapies that work for people. We have a bispecific antibody that may work well for people. So that's a bit of a limitation and something that we may all throw in. But patients who receive gene therapy, and this is yet possibly another limitation, you're not necessarily cured because you may still need to receive factor infusions or treatments with factor replacement therapy or surgical procedures, depending on your baseline factor level after the gene therapy has been completed, or in a situation where you are a part of a traumatic event. So just again, some food for thought in terms of general limitations with gene therapy. All important questions that have to be addressed, not only by patients, it has to be addressed by providers, hemophilia doctors, and it has to be addressed by payers. So these are all questions across the board that when you think of gene therapy and the possibility of it being available, these are some of the things that we ask. And the final one would be treatment in terms of if you have gene therapy potentially, and you have stabilized concentrations of factor that would be available, it does not change any existing joint damage. And you guys are accustomed to hearing that because that actually applies to any therapy in terms of hemophilia. We cannot change what has already happened in a joint study. Now, in terms of gene therapy, what have we talked about so that we can have some questions and quick discussion in terms of where do we go from here? And I see some things in the chat, so I can't wait to see what your questions are. So hemophilia treatment, we've discussed, has advanced significantly over the past several decades, but we still have unmet needs, right? The ones that we reviewed. So gene therapy represents a significant opportunity possibly to meet some of these needs. And there are some promising results in clinical trials. Not all patients will be candidates or will even want to receive gene therapy. And there may still be a need to use factor replacement therapy under certain conditions, even after receiving gene therapy in some patients. So it is important that we stay the course in terms of the concept of gene therapy. It is important that we stay the course with treatment, that we minimize we minimize joint damage as much as possible prior to the initiation of gene therapy, if you're even considering or thinking that it may be something that you want to have a discussion about with your provider, to ask questions. Is this right for me? You may have a lot of questions. Now, I want to review really quickly. Oh, and of course, remember that post-approval surveillance that will continue even when gene therapy is approved. I forgot to add that point. So let's shift gears at the end of this, just a couple of minutes, and go back. And we're going to take a look now at some of those emerging therapies. So restoring that balance with a non-factor replacement like therapy, where we are taking advantage of our body's anticoagulant system. So just like you have a procoagulant system where factor 8 and factor 9 and factor 10 are very important in the process of forming and establishing a clot. Well, so that the clot isn't the size of Montana, you have an anticoagulation system so that there's a balance. The clot is just the right size for the injury that occurred. So we have anticoagulants, and we are now taking advantage of the possibility of inhibiting or stopping those anticoagulants to sort of restore or develop balance to have ongoing hemostasis or clot formation, appropriate clot formation. So what you see here are a few examples of some of the therapies that are available. And I just put them in a table form for you, just so we can review this. So I know that Dr. Redding is going to cover, or has covered, a lot of great information about imosuzumab. That was one of our novel agents that has now been FDA approved, that bispecific monoclonal antibody. It is available for use for patients with hemophilia A with and without inhibitors. There are still lots of questions surrounding therapy with imosuzumab. So do you give imosuzumab with immune tolerance? Do you give imosuzumab, again, with some factor 8 therapy? What happens for patients with surgical procedures? So there are a lot of questions that still exist, and we have ongoing clinical trials to try to address or answer some of those questions. The remaining items are items that are still in, or therapeutic options are still in clinical trial. So fitusiran is a small interfering RNA. So instead of RNA sort of reading the DNA and producing the protein, RNA with a little small interfering RNA that will block the development of antithrombin 3, one of those natural anticoagulants that we have, to promote clot formation, again, sort of restoring that balance. It's currently in phase 3. Concizumab, it is an antibody, a monoclonal antibody against TIF. So tissue factor pathway inhibitor is another one of those anticoagulants that binds to tissue factor and other factors to stop or inhibit the clotting process. Again, so that you don't have a clot the size of Montana, so the clot is appropriate for the injury that has occurred. Well, concizumab is an antibody that binds to TIFP, blocking that anticoagulant property, again, allowing coagulation to take place, and you have, once again, potentially the restoration in terms of balance, procoagulants, anticoagulants. The next two products, the one starting there with PF, PF 06741-086 is another monoclonal antibody, and that is in phase 3, as well as there was previously another one. You see that BAY 1093884. That one was stopped in 2019. And so maybe we'll hear more information about that down the line. But we also have others that are in preclinical development. These are several that are kind of at the top of the list. Activated protein C inhibitors, I know that there are a couple of those, as well as protein S and small interfering RNA. Again, kind of like putting a nail or something in a spinning wheel. And another monoclonal antibody that will bind to factor 9, bind to factor 10 is also activated factor 9, factor 10 is also in clinical development. So if you have any questions about those, we can answer that as well. But just a general idea of what's kind of out there and on the horizon as you consider where do we go from here with gene therapy. Okay, so I have left a little time at the end, and I would love to have an opportunity to address your questions.
Thank you so much, Dr. Singleton. That was really great. I'm going to actually have one of my colleagues who is participating in the session today, Adeli Lopez, as chat manager. She's got a couple of really great questions for you.
All right, great. Shoot.
So we have some questions from the audience. One of them is, for how long these gene therapies are effective in hemophilia? Once injected, does this have lifelong effects?
So that is actually one of the really, I'm going to go back to this gene therapy side. So as we talk about the efficacy and the safety of gene therapy, those are the questions that are being answered in those clinical trials. So as you look here at, for example, phase 2, phase 3, how well does gene therapy work? Also, with your question, how long would it last? Will you have factor 8 or factor 9 in the appropriate concentration, and how long will it last? Does it last 2 years, 3 years, 7 years, 5 years, 6 months? You will have that information once a clinical trial has been completed, presented to the FDA, and then finally approved. So we don't know necessarily the answer to that question yet finally. However, there is some data that is available that suggests that there are patients who are participating in gene therapy clinical trials, that they are sustaining factor levels over 3, 4, and 5 years. And was there a second part of that question I missed? How long and
how long these gene therapies are effective, and does this have lifelong effects?
And in terms of, again, safety, any possible effects, again, that question is also being reviewed, studied, and answered in clinical trials. So those are two great questions, because you hit the nail right on the head in terms of what is being evaluated in gene therapy clinical trials using gene transfer. Smart question. You have another one?
Yes. So for patients needing factor after gene therapy, such as trauma or surgery, would a SHL or EHL be more appropriate in these situations?
You know what? That's a super, super good question, but I'm going to have to use the real answer. And I'm sort of chuckling to myself as I say that, because I think that as hematologists, especially hemophilia providers, when we provide this answer, especially when we're being asked very specific questions as key opinion leaders, everybody's like, it depends. It depends. It really depends. So it would depend on if you were a candidate and received gene transfer in a gene therapy clinical trial. It would depend on your sort of baseline post-gene therapy factor levels. Like, where are you after that? Is it 30%? Is it 25%? Is it 75%? Because that goes back to the standards that we have in terms of treating patients with hemophilia. So I'm sure that you're very familiar. If there's a surgical procedure, we have parameters typically that we want to stay within for severe hemophilia. Major surgical procedures in severe patients. I probably need to drink more of my Diet Coke. But if that patient is having a minor surgical procedure, it would change. So it really depends on the patient, the factor levels that are present after gene transfer in a gene therapy clinical trial, and what's happening. Is it a major surgical procedure? Is it a minor surgical procedure? Do you have the ability to infuse? What happens? So we use all of that to determine the patient's history overall. So we will use all of that to determine if a short or standard, shouldn't say short, standard half-life factor replacement product would be appropriate versus an extended half-life factor replacement product. And I didn't even say anything about sometimes the limitations that we may have if we're talking about a surgical procedure and in the hospital setting. So yeah, that's another depends. It depends on if the hospital had it available. It depends on what your product is at home. So it would depend on a number of things, but amazing question.
Okay,
Another quick question?
Yeah, one more since we are running out of time. A
I'll try
patient
to
with severe Hem A asked why should he participate in the current gene therapy trials, which may result in a mild factor level, when in the future there could be a gene therapy that may result in normal factor levels. How is the best way to answer this?
I don't think that you could answer that broadly for a group of people. I do think that there are some people, if you, from a general health standpoint, meet the eligibility requirements to participate. And if you are an adult with hemophilia A or hemophilia B, and you are interested in pursuing it, I think that it would be important to have a conversation with your hemophilia doctor, your HTC, to determine why or why not in terms of participating in a clinical trial. For many people, clinical trial participation is something that they're very motivated to participate in. Many people may consider it important to participate because of the possibility of the outcome. Maybe for that particular patient, the safety of the trial is, in general, as we talk about risk factors, maybe a risk that's willing to take as we look at risks versus benefits. All therapies that we currently use in hemophilia and otherwise all have to go through this clinical trial process. So there are certainly people that participate in clinical trials, but if it's right for you as an individual, that is something that you really should have a conversation with your provider about, but try to read a little more, have questions. So the next time you see your provider, if you even think that it's something that you may be appropriate for, or just in general to understand what's happening in terms of hemophilia treatment options and with gene therapy, going back to the title, where do we go from here? I think it would be important to have that conversation on an individual basis. So I hope that that answered that question. I think in general, clinical trial participation, those of us who conduct clinical trials, we each play a very critical role in terms of all of these innovative therapies that I just mentioned and the progress and success that we've seen, not only in the hemophilia community, but in general. So it just depends on your situation.
Well, I wish we had another 30 minutes for questions because there's some pretty amazing ones in the chat and the Q&A. But unfortunately, we have to wrap this session up. Dr. Singleton, excellent session. I personally learned a lot, and I know our audience did too. And again, the quality of questions were outstanding.